Hello and welcome back to the CRISP TV. I am your host. My name is Dr. Abad Khan. I am an interventional cardiologist practicing in St. Joseph Hospital, Ghaziabad. With me now we have Dr. Bhavesh Popat. Who is a distinguished vascular and interventional radiologist with a robust career spanning over more than 15 years. He has been awarded with Times Healthcare Leader Award and he is a treasurer and executive member for governing body for interventional radiologists in India. Currently, he's a consultant and interventional radiologist and vascular specialist at the and director of Symbiosis Hospital. Dr. Bhavesh, welcome.
Pleasure.
So we just had a word, and everybody was listening to your talk yesterday to the importance of the access sites. And you yesterday presented data from the Pulse registry for TAVI access and the closure, which was clear. For coronary intervention, also data is very clear now for a long time. Why do you think the ultrasound guided access is still not getting streamlined in India as a standard procedure protocol and still considered a niche work?
Okay, so I think there are a couple of reasons for that. I think one, primarily the way cardiologists get trained in institutes for years together, they get trained in doing 2D echoes themselves, and when you ask them to do echoes, they're comfortable doing that, they're not bothered. But they generally are never trained in a focused way in doing accesses using ultrasound guidance. Primarily for a couple of reasons. One, a lot of institutes don't have ultrasound dedicated to cath labs. They're a part of the sono department, so they don't have that access. So probably lack of habit of doing it on a regular basis. I think that's the most. So developing a habit is something that people need to do, I think. And then once you have the habit, you develop the skill as well. So it's a matter of time. If I'm sure if cardiologists can spend time in learning IVUS and they utilize it in doing their left main procedures in so beautifully, to learn ultrasound to take accesses is not a difficult job. I think it's more to do with sheer habit formation.
Perfect. He's playing it simple, and absolutely that is what it is needed. You have to develop a habit for doing these ultrasound accesses, and that is how you're going to have an expertise on that. And extending upon the topic you just mentioned, do you also feel that interventional cardiologists now should get trained along with radiologists for a couple of weeks or month maybe for better understanding of the probe usage for the vascular access, starting with the DM program itself?
So I think learning ultrasound for access is something which is almost a must now for almost everybody should have, especially in the cardiology fora where TAVI is getting across the country in a very beautiful way. Access without ultrasound in TAVI always is almost criminal in today's times. And to get that proficiency well, getting coronaries, PCIs with ultrasound access would make sense. Now, ideally, I would say yes, learning with an IR makes sense. At the same time, now IRs or interventional radiologists are available across the country as well. There is no harm collaborating. Like lot of times when we would do our aortic aneurysms, our stent graft procedures, and our aortic aneurysms grafts are 24 French, so they're like big bore. So now you can't do them percute every time. Sometimes you have bad disease and you have to collaborate with a vascular surgeon who would open up for you, or a cardiac surgeon who would open up the femoral artery. You do arteriotomy and do. So we do collaborate, and I think I would say training as well as collaborating with the IR colleagues would make a lot of sense.
So absolutely. So it is not only the part of the training process. The learning is a continuous process, and even if you are getting trained with the radiologist, with the interventional radiologist, even after that, the two or maybe the three dimensions of including a vascular specialist also, this can help you build a program and maybe have better results for your patients.
Absolutely.
So since you yourself do a lot of large bore accesses, you just mentioned for 22 French, 24 French, as well as small bore access for arteries and venous access, do you feel that ultrasound usage should be for all coronary intervention and not only for the large bore access only?
I think so. I think so. Imagine you've done a complex left main using your IVUS or OCT. You've done cutting balloon. Probably you've done your IVL. You've done everything right, and you've got a beautiful result at the end of 2 hours. And you have a bad hematoma which is causing hypotension. It's a killer combination. I mean, I've seen my colleagues, some of them who don't use it, panic late in the evenings, and then they start wondering whether there is a stent thrombosis which is happening, which is causing all these events, or there's a hematoma which is happening in the groin, which is causing all these things. I think a lot of anxiety would go away when you take a very secure access, you know. So I think getting used to doing it more in most coronaries would make a lot of sense, you know.
Absolutely. Safety is why we are doing all these things to make the patients better. And if we take the precautions for the safety as the initial part, why not do for all interventions, not only for large bore accesses? So now with the availability of so many vascular closure devices, we have suture-based, as you mentioned also yesterday, ProGlide, Prostar, collagen-based, now patch-based also are all coming. Do you feel that all interventional cardiologists and all interventional radiologists should be well versed with all the type of devices, or maybe just you should be comfortable doing one of them and just continue doing them?
I think knowing all makes sense. You never know when you have come across with a situation where you have to use a particular device. But at the same time, everybody will have couple of devices. You know, say one suture-based ProGlide and one collagen-based device, whichever you're comfortable with, either an angioseal or say this one the Merrill device,
Yeah,
you know.
yeah.
So either of these, I think at any point in time, if both of these, either suture based and collagen based, you used to it, you have to do again and again to make sure that you don't falter in your steps. So preferably one or two devices regularly, but you need to know almost all of them.
So as the need demands, Dr. Bhavesh is saying that as the need demands, you should be wide open with your brains and eyes, and your skills should be developed for all. But actually, just practicing on one or two, maybe making the most sense of it. What is your preferred access vascular closure access device you are using in your labs?
So I think at any point in time, we always have a ProGlide as well as AngioSeal available to us in our lab, and both of them are available. Uh, mm, Once in a while, we use both of them regularly. So it depends on what kind of vessel we are dealing with, and how comfortable we are to use ProGlide on that particular day. But I think preferred choice is ProGlide, but we keep AngioSeals always available as and when required. We use that.
Perfect, perfect. And what do you see the way forward in device technology, and how do you see that vascular acupuncture and the closing this evolves in future? Do you still see that this will remain the angioseal or a collagen based, or maybe a wire based, or maybe a puncture based, or do you see that this also progresses and evolves to a new future?
I guess suture based is what seems to be the most natural extension of a surgical closure. So that seems to be not dying at all. I mean, I really don't see any reason why that should die off, you know, and that's something which should progress and in fact improvise only over the period of time. So suture based surely would remain, I'm sure. People have tried everything with a collagen based foot plate with a collagen plug. People have tried exoseals also, you know. I think there is a lot of scope for that, because there is always a fear of the foot plate getting embolized distally, you know. So I'm sure future developments are going to happen in that area, and probably a patch based or something which makes sure that you are secure more well with the access would make probably go in that direction.
Absolutely. Maybe one of the we like to have more safety on these devices as the technology progresses, and that is exactly what Dr. Bhavesh is trying to say. And Dr. Bhavesh, how do you find the conference just from an interventional radiology perspective? That how do you feel that this CRISPR 25 has been?
Oh, it's been wonderful. I think beautiful experience. I think the way the, the the academic or the scientific content has been designed with both the aspect. I think a lot of academic contents, whenever conferences happen, focus only on cardiology or only on IR. And I think this one, with an entire hall dedicated to 360 development, I think right from practice developments to creating clinics to speaking on how to raise funds for developing your setups. I think it covers almost every aspect apart from the scientific content that's going on in one entire hall. You know, so great minds get together, and I'm sure a lot of these intelligent minds are putting their effort in developing a better scientific content and consensus every day.
Perfect. And that is how you progress. And thank you, Dr.
Thank
Bhavesh.
you.
Thank you
Thank
for
you. The pleasure
having
is mine.
on the
Pleasure is
CRISP
mine.
TV.
Thank
And
you.
we'll see you in the next podcast. Thank you.
Thank you. Thank you.